And you mentioned the immune treatments because, as we've discussed, the PNS and PCD is an immune response to the cancer. So what does it look like? They may not know that there's a malignancy there from the cancer perspective, but in order to stop the immune response, what are the treatments that are used for PNS?
So the most important one is to, of course, identify the malignancy and treat that, because it's expected that or is hypothesized that the cancer treatment should slow down the immune response. Unfortunately, that's not always the case. Even though sometimes patients are in full remission of their cancer, they continue to have ongoing inflammation in the nervous system. So it's a twofold approach in which patients receive cancer therapy to address what is triggering the problem in concomitance to, for example, treatments like plasma exchange, which can remove antibodies from the circulation, corticosteroids, which have a broad way in the way that it works, or other medications like IVIG. Sometimes patients receive treatments for their cancers that cause a degree of immune suppression, meaning the treatment for the cancer is in a way like killing two birds with one stone. So you're addressing the cancer, and that medication can cause a degree of immune suppression, dampening the immune response and helping the neurologic symptoms. So it's often something that we work in close collaboration with our medical oncologists to define what the best treatment approaches are. But going back to the time is brain analogy, I think that it's very, very important to treat this as a medical emergency. That's really very important, because patients don't have the luxury of waiting weeks to be, scheduling the surgery for, addressing the issue. They don't have the luxury of waiting, weeks to months to start, chemotherapies and to receive immunotherapy. So sometimes we essentially have to just admit the patients to the hospital quickly to get the workup done, to get the surgeries done quickly and get them on treatment fast.
That's a really important point, because kind of going back to our conversation, that conventional wisdom would tell you, this is very early stage when you're looking across a patient population and, okay, this hasn't spread, and, perhaps we can fit them into a surgery schedule or what have you. But when the cancer is presenting with the PNS, it really needs to be accelerated, because that immune response will keep on going until there's not the malignancy to attack, or there's some treatment given that can be suppressing the immune system. And I think that's huge. I think that's one of our goals too, is to help educate oncologists that there is that different need for the treatment, the pathway for the treatment. So we talked a little bit about IVIG and plasma exchange and perhaps just steroid treatments. Is there any other treatment options for PNS?
So sometimes we use some treatments that are so-called cytotoxic therapies, like medications that are chemotherapies that are utilized with the goal of suppressing the immune system rather than treating cancer. There's a medication called cyclophosphamide. Sometimes B-cell depleting therapies like rituximab have been used, but I think that it's really also another area of unmet need, the identification of more targeted treatments, because the treatments that we use nowadays are the same treatments that have been utilized for decades. So I think that, we really need to start looking elsewhere besides these drugs that we currently use, more specific targets that we can try to individualize depending on, what we're seeing on the spinal fluid. That may be a very important avenue to explore.
There's probably a lot of research to be found, treatments that kind of address the PNS but not affect the cerebellum, things like that, because you're typically wanting to penetrate the blood-brain barrier, right? Versus in this scenario that we don't want that, trying to find a mechanism to maybe turn that off, so there's not the attack of the brain and of the cerebellum in particular. So what do you see the future of that looking like? I guess research?
Yeah, certainly we still are lacking, more biomarkers that can help us assess severity, for example. We really don't know that much about the specific immune pathways that are, turned on and off in these conditions. Even the pathology of these disorders is understudied. So, there's still a lot of work to do in all those arenas.
Mm-hmm.